Hello, this is Dr. Hausinger, and this covers Chapter 8 in your book, Youth Prevention, in the Babor text. So on this first screen here, we have some images that you may or may not be familiar with. We have McGruff the crime dog, Just Say No to Drugs. We have our Dare Tiger, Drug Abuse Resistance Education, our lion. And then we have a newer one from the 90s and 2000s, Be Like Me, Drug Free. Okay. So we have different programs that look at drug prevention in youth. And we're generally looking at illicit substances, and that's the title of your chapter, Preventing Illicit Drug Use in Young People. The chapter summarizes research on the programs designed to prevent, delay, or reduce the use of illicit drugs and drug-related problems. The bulk of the research to date surrounds adolescents, not so much children, but adolescents, as use is more likely to begin in adolescence. Historically, models have focused on an educational approach with the dangers of use, objective knowledge of substances, so that would be like when the DARE officer comes in and talks to you about, this drug does this drug does that, and might bring in a case of drugs for the kids to look at. And low self-esteem as a precursor to use. Now, it's important to note that most research is concentrated on a fairly narrow band of strategies. And most of the research has been limited to the United States. Okay. So we have different preventions of classifications. Universal prevention, which is looking at everyone regardless of risk. So that might be like a DARE program where the entire class or the entire school hears a lecture from an officer. We have selective prevention, which is where we look specifically at higher risk populations. And then we have indicated prevention, which is prevention for individuals that are at risk for poor health. Great. So to go a little bit deeper into that, we have environmental prevention, which looks at legal requirements, economic disincentives, and situational crime prevention. Developmental prevention, which is more family-based, looking at parental monitoring practices, teacher behavior management strategies, and individual social competencies. And then informational prevention, which you're probably most familiar with, the mass media campaigns to raise awareness or norm setting to challenge preconceptions. So this would be like, if you remember from the 80s and then again in the 90s, this is your brain on drugs with the egg and the frying pan. That would be an example of a mass media campaign. So what works and what does not work? Youth prevention programs can be grouped into the following categories. We have school-based programs, family-based, and community-based. And you might be familiar with this, the drug-free from the Substance Abuse Council. In school-based prevention, what works is looking at social competence and social influence, which can involve building skills. We focus on changing the school climate versus changing the individual. Okay. And programs don't have to have drug-specific content. Factors that predict the development of a drug problem are also predictive of school failure, social isolation, aggression, and other problems. So I know that we've repeated this throughout the courses, but we're looking at doing things that help to reduce risk and increase protective factors. Okay? So many of the programs that work don't even mention drugs and alcohol. What we're trying to do is to give students the skills so that they wouldn't want to use drugs or alcohol. Okay. And this can be, all of this needs to be age-based. We might play games, for example, the good behavior game for elementary school children, and then other activities for adolescents. So it's very important that it is age competent. Okay. Some schools have played around with drug testing, which hasn't been very effective, mandatory random student drug testing. led to lower rates of self-reported use, but it's difficult to enforce. Okay. What is difficult also is the didactic info only. For example, drug information education, didactic meaning, it's not really collaborative. It's just being taught without a lot of feedback. So what does work is small groups, collaborative things, exercises, giving people skills and coping mechanisms to increase their protective factors. The next tier of services, we have our family and community-based prevention. And what works here is developmental prevention, which stresses an increase in protective factors while reducing risk factors, including social and communication skills. And these are things that can be taught to families. Your book gives several examples of programs that would be used. Some of these programs are substance-based, for example, specifically to reduce adolescent marijuana use. Some programs are effective for marijuana use, but not other drug use. So some of these might be drug-specific. And these programs are usually based on theories of community organization and participation, and they often offer multi-component interventions comprising environmental, developmental, and informational approaches that target schools, families, peers, and the wider community in an effort to shape drug use norms. Okay, so we're looking more at meso level here. Okay. What does not work? Child and parent dyads, the exception for that is the program that works well for marijuana, but it does not work for other substances. And we do have mixed results for different substances. Here's an example of a mass media campaign. This website here, the methproject.org, uses a little bit of shock, and they have these 30-second ads that they produced, and they're very, very graphic. This is normal on meth. This is not normal otherwise. And they have the mugshot game where you can match the drug user to their mugshot and look at how much damage somebody has done to their physical appearance based off of their mugshot. And here's an example of a poster that you might see. Okay. So you can see where the person had maybe some periods of sobriety for a little bit and might have gotten better in this time frame. So almost a whole year here, and then rapidly decreased, and you can see that digression there. Okay, if you do go to this website, it can be very triggering. There's some great information on there specifically about what meth does to the body, but the images are very disturbing, as are the 30-second ads. Okay, Happy Bunny was really popular in the 90s, and we had these posters hanging up in our adolescent treatment ward. Meth, finally a simple way to become a twitchy idiot in no time. Okay. And then ads that are geared right towards teens. So we have a video game here. Okay. So what we're getting from these ads is that drugs are bad. However, we're not getting any skills, we're not getting any alternatives, we're just getting fear, and that's not overly effective because there's no conversation here to be had. The authors of several studies for the WHO concluded that the use of mass media alone, particularly in the presence of other countervailing influences such as pro-drug club culture, pro-drug music, drug-using role models, and exposure to images of drug use, was not an effective way to reduce psychoactive substance use, although media campaigns in some cases were capable of raising awareness of the negative consequences of use. So what we really see here is, yes, we know that drug use can be problematic, but we need the other side of that conversation. What leads to drug use? How can we prevent it? What skills can I cultivate so that I don't choose drug use? Okay. There's some other ads for you. Remember, kids who take drugs are losers. Okay, so it's very negative here. Be wise, not weird. Okay. Rubbing tuna fish in your armpits does not make a good deodorant, and itchy red skin splotches caused by abusing prescription drugs look nasty, painfully obvious. So again, we have ads that are pretty shameful, but don't really give us any other options here. Just don't do it, which we know is not an effective strategy. Okay. Here are some links that I would like you to check out. This one, the Australian drunk driving PSA, they started it in the late 70s or 80s because there were so many DUI fatalities in Australia, and they show it especially around Christmas time, and they drastically reduced the amount of drunk driving incidences and fatalities that they had. It is graphic. Okay. This one made me cry because it's about a dog. The dog doesn't die. The dog is okay. Basically, a guy goes out drinking and his dog's waiting for him at home, and does he or does he not come back? So it's a unique ad because it looks at a different side. Okay. This is a classic one from the late 80s, early 90s, where a father walks in and his son has a box. It looks like maybe full of marijuana. And he goes, "Where did you learn it?" "I learned it from you." The Rachel Lee Cook, Brain on Drugs. There's an earlier one of that too. She updated it recently with drug policy awareness. This is your brain on drug policy versus on drugs. I encourage you to look at that. You can find it on the drug policy link, which is in the first week's Moodle module. This one is about cocaine, party all night. The Navy put out a PSA about bath salts because they had anticipated it to be a very big problem because it's difficult to detect in drug tests and it's legal. You can order it in the mail. And then this one here is an example of the meth project. There are several different ads. And this one is, there's two girls at a gas station, and the one girl goes up to this guy and said, "You can do anything you want to me for $50. And the guy's like, "Well, what about her?" And she goes, "Sure." And first off, they look normal. And it goes, "This isn't normal." And then it pans out, and then you see that they have sores and marks. And it goes, "But on meth it is." Right. That one's potentially pretty triggering and disturbing. But these are all examples of mass media campaigns. But they warn us and increase awareness, but they don't tell us how not to use drugs. Okay, so pros, they provide us with information. They're usually substance-specific media campaigns, so we get a little bit of information. It increases overall awareness, but they're ineffective when used as the sole means of prevention, and they're often used as a go-to without further discussion or follow-up. It's kind of the equivalent of saying, "Don't do drugs," and then that's it. And people are fairly smart, and kids and adults and adolescents, they all want answers, and they want to be addressed in a way that shows that they're intelligent. And just saying, "Don't do this," that's not good enough. We really need to do more in terms of engaging people in a conversation and skill building. So what works? We spent a lot of time talking about the inefficiencies. Developmental prevention efforts are more effective than information-only efforts. So this is teaching skills at the specific developmental increments, right? So we're looking at early adolescence, mid-adolescence, and late adolescence. There are huge differences developmentally, and especially from middle school to high school, we see really, really big differences in cognitive and emotional development and physical development as well. So we have to tailor the prevention programs to the developmental stage of our audience. Programs have to be implemented and followed to completion for full effectiveness. That's true of all programs, if it's family-based or community-based or school-based. Okay. Compliance, I guess. Cultural adaptations of universal prevention measures can be utilized for selective and indicated prevention. Okay. So remember here that indicated prevention would be for people that are at risk for poor health. Okay. So this might be a little bit of harm reduction. It might be a little bit of education and access to materials for good health. Research outside of universal prevention efforts is limited and necessitates further study, especially that it's mostly limited to the United States. We do have some really good resources. SAMHSA, Office of Adolescent Health, which is in your Moodle module this week, World Health Organization, The suicide prevention website is absolutely fantastic. It has a lot of resources that work well for substance abuse because, again, we have similar risk factors for substance use and suicidality. And the benefits for modest prevention results do outweigh the modest costs despite the modest results. So, in essence, prevention is better. Some prevention is better than no prevention at all. So, it doesn't matter that it might not be a huge result, modest results are okay, and they're better than no results at all.